much. Difficult question, difficult answer. Difficult answer in ARDS patients, but also difficult answer in surgical patients. So these are my conflict of interest. So should we use recruitment maneuvers in all surgical patients? Well, let's try to answer these questions. What we have to know is that recruitment maneuvers only aim to restore functional lung volume, reverse alveolar collapse. So this is the first thing that we have to think when we decide or not to perform a recruitment maneuver in a surgical patient. So you know quite well these slides that have been presented by many colleagues in many congresses, showing us how atelectasis appear when we use anesthesia, when we put the patients under mechanical ventilation, and this atelectasis can still there for several days after surgery. Based on some data from the 90s from the group of Stierna, well, currently we assume that the prevalence of intraoperative atelectasis is as high as 90% of patients undergoing surgery and mechanical ventilation. And this is the first thing that we have to think about. If today is the same incidence with all the new things that we are doing in the surgery room, and this will help us to answer if we have to recruit or not recruit all surgical patients. The idea to recruit is, well, to restore the functional lung volume. This way we will try to minimize ventilator-induced lung injury, promoted by the alveolar collapse, this tidal recruitment, or even the tidal overdistension that it can be produced even when using low tidal volume. We have a high amount of alveolar collapse. So this is the main idea of why we should recruit the lungs in the surgery. We should think also in the driving pressure, which, as you know, is plateau pressure minus PEEP, and monitors functional lung volume. So it gives us an idea when the lung gets worse or we are having some atelectasis in our lung. And there are some data telling us that seems the most important predictor of PPCS in surgical patients. So has been found an association by several observational studies between each centimeters of water of increase in driving pressure and the risk of developing PPCS. So this is another reason to think why we should recruit or not recruit the surgical patients with healthy lungs, just to prevent the appearance of postoperative pulmonary complications. The main thing is that until today, there is no data telling us a correlation or an association between intraoperative atelectasis and other postoperative pulmonary complications. This is some of our data that, well, we did not publish yet this data, but comes from the database of the IPROVE trial, almost 1,000 patients undergoing abdominal surgery. And in a sub-analysis that we are performing now, we are going to send next week to the journal, let's hope if it's finally published or not, we have found this correlation between intraoperative atelectasis and moderate to severe postoperative pulmonary complication. We exclude mild postoperative pulmonary complication. So it's another reason to think that we should try to make an open lung approach in high-risk surgical patients. The only way to restore functional lung volume, the only way to treat those atelectasis is by performing a recruitment maneuver, but also after the recruitment maneuver, we should set a level of PEEP that prevents alveolar recollapse. You have, well, these slides. I'm sure that most of you already know that if we set a PEEP value, well, we are not going to reopen this collapse that appear after the induction. If we recruit the lung, but we do not set the level of PEEP, after recruitment maneuver, collapse will appear again. So we need to recruit and to set the minimum amount of PEEP that prevents alveolar recollapse. Many studies have shown, most of them, if not all of them, in healthy lung surgical patients, physiological benefits of this approach. This is one of our papers. So when you perform a recruitment maneuver, you can see here the recruitment maneuver. This is the PEEP value, airway pressure, and the PEEP trial. This is the trend of the compliance. When you perform a recruitment maneuver, you improve respiratory mechanics, you improve lung mechanics, you improve lung efficiency, you improve oxygenation. So the benefits of the recruitment maneuver in surgical patients, physiological benefits, are very well known, and I think there is no paper that agrees that when we recruit the lung, we improve from a physiological point of view our lung condition. But how about outcomes? This really improves or decreases the risk of VILI and decreases PPC, postoperative pulmonary complications. We have less data in the intraoperative patients, but for example, this is a really nice sub-analysis of the VILI trial, one of the most well-known trials in abdominal surgery patients with almost 900 patients. So you can see here the two strategies, the higher PIP group with recruitment maneuvers here, and the lower PIP group. And you can see that with this approach of recruitment maneuver plus PIP, the risk of intratidal recruitment, the recruitment was significantly lower when compared to very low PIP values between 0 and 2 without recruitment maneuver, without increasing the risk of tidal overdistension. But what the randomized controlled trials tell us? Well, we have now 5 randomized controlled trials. The first 2, well, the problem of these ones is that they make a global approach of different tidal volumes and different PIP settings, so it's really difficult to fit the effect or the protected effect of the recruitment maneuver and PIP, because they also use in the study group a lower tidal volume. But they found benefits of this strategy of low tidal volume and open lung approach. The ProVilo study, using the same tidal volume in both groups, abdominal surgery patients with a moderate to high risk of suffering PPCs, well, they not found differences in the composite of mild, moderate, and severe postoperative pulmonary complications, which results that surprised all of us, but these were their findings. The Brazilian study is in cardiac surgery patients. Well, they compare, again, same tidal volume in both groups with 2 open lung approaches. Let's say a mild open lung approach with a site and a lower PIP value and a higher or more aggressive recruitment maneuver and higher PIP values, and they found that this open lung approach reduced moderate to severe PPCs. And finally, our trial is a little bit more complex because we not only protocolize the intraoperative period, but also the postoperative period during a few hours with CPAP. But intraoperatively, we use the same tidal volume in both groups. We did not recruit the lungs and use a PIP of 5 in the control group. And we perform a stepwise recruitment maneuver and individualized PIP in the study group. And we saw as a secondary outcome a reduction in postoperative pulmonary complication. The trial was not positive for the primary outcome, that was a composite of systemic and pulmonary complications. It was not positive, we did not find differences, but we found differences in pulmonary complications comparing these 2 strategies. However, now we have some data, recent data, telling us, some studies telling us that it is not necessary to perform a recruitment maneuver to keep the lung open during surgery, which means that if the lung is already open, why to recruit the lung? Which one is going to be the benefit? If we want to restore the lung volume, we want to reverse atelectasis. So if we do not have atelectasis, why we should perform a recruitment maneuver? And this has been the big problem of these big trials. You were in 2 groups, control group without recruitment and a study group with recruitment. But no one evaluated if you had or not atelectasis. So we have some data telling us, for example, this is in non-abdominal surgery patients, that just keeping a PIP of 7 to 9, it's enough to keep the lung open. So these patients are not going to obtain any benefit if we recruit these lungs. They will corroborate this with the CT scan and with the blood gas analysis. We performed this trial trying to optimize or to perform the recruitment maneuver by using the SpO2 while breathing room air, 0.21 FiO2, based on the knowledge of this SpO2 FiO2 diagram. This is the FiO2 trial that we performed, and I'm showing you this trial because we obtained some interesting results in these patients, and those are the results. We had were patients undergoing laparoscopy, and 25% of the patients, when we decreased the FiO2 during surgery, the SpO2 did not decrease. It was 77, 97, 98, 99, which means that they did not have SUNT. so they did not have alveolar collapse. So to those patients, we did not perform this open line approach. We performed the open line approach with those patients that the SpO2 dropped. When we compare these two patients, those patients that the SpO2 did not drop and the other patients after we recruit the lung and we obtain the open lung PEEP, there were no differences in oxygenation, there were no differences in respiratory system mechanics, there were no differences in lung mechanics, there were no differences in lung efficiency, which means that the lung condition was the same at that moment. Those patients that the SpO2 dropped and weren't recruited and select an open lung PEEP, and those patients that we did nothing, just maintain this PEEP of 5 that was set at the beginning of the study. When we obtained this data, we came back to the database that we have of these almost 1,000 patients of the IPROVE trial, and we found that 36 of the patients without recruitment maneuvers, just with the PEEP of 5 of this control group, had an open lung condition. So based on the PA-FiO2 ratio that was over 400, which means that 36% of the patients that were not recruited were in the control group already had an open lung condition. But also we found, and sorry I didn't put it, that 32% of the patients that were in the study group and that were recruited, when we started the recruitment maneuver, they had an open lung condition. So 32% of the patients did not obtain any benefit for being in the study group. So we should rethink the approach that we are doing in our surgery patients when we decide to perform a recruitment maneuver. And this is our proposal after having all these data. So the first step that we now do is to diagnose if the patient has or has not alveolar collapse, if the patient is going or is not going to benefit from this recruitment maneuver. How can we do that? Well, obviously, the ETI is the best tool, but we do not have it in the surgery room. Lung ultrasound, a really nice tool, but we do not have it in all surgery rooms. And we use the air test or the SpO2. So we perform the induction, and after the patient is intubated and under controlled mechanical ventilation, we reduce the FiO2 to 0.21. If the SpO2 is 97 or higher, we do nothing. We just keep the PEEP value. If the SpO2 decreases below 97, 92, 90, that patient that 5 minutes before was with 98% of oxygenation, we recruit the lung. So this is the way now we approach to these patients. So the answer is when to recruit the patient. Well, we should recruit the patient when the patient has alveolar collapse. So we need to diagnose this alveolar collapse before we decide to recruit or not recruit these patients. And we have different non-invasive techniques such as the SpO2, lung ultrasound, or the electrical impedance tomography. Obviously, this is a personal opinion, but based in our own clinical data. Well, thank you very much.